Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Imagine you're looking at a liver on the pathology bench. Your patient successfully bridged to transplant. You were the interventionalist who did the Y90 radiation segmentectomy. You mapped the vessels perfectly, you calculated the dosimetry completely by the book, and you delivered that gold standard 400 gray of radiation right to that segment.
Technically speaking, a flawless case.
But then the pathology report comes back, and the pathologist found like 25% viable tumor cells sitting right there in the margins.
Oh, man. Yeah.
Right. I mean, you did everything current guidelines asked of you, but the biology just didn't care.
And that scenario right there is the quiet frustration of every multidisciplinary tumor board across the country. I mean, we rely on a target dose, assuming this uniform biological effect, but the tissue tells a completely different story.
Which is exactly why we're tearing into the COBRAS study today. That stands for the Consortium on Bridging Radiation Segmentectomy.
Right, published in Radiology 2026 by Berman et al.
Yeah, and we're also cross-referencing it with a few internal institutional briefings we've got our hands on. So the mission of this deep dive is to explore why relying on that 400 gray single compartment dose is, well, it's just no longer sufficient on its own.
Not at all.
We're going to examine how stacking 4 very specific procedural parameters, basically variables you actually control on the day of delivery, can drive complete pathologic necrosis, or CPN, from a baseline of 74% all the way up to 91%.
Which is huge. I mean, for context, when you have a patient with treatment-naive HCC who's bridging to liver transplant, CPN at explant is the biological finish line.
Right. It's the gold standard.
Exactly. The AASLD recognizes it as the primary predictor for post-transplant freedom from recurrence, not to mention overall survival. I mean, when the surgeon takes that native liver out, you want absolutely zero living cancer cells.
Because if a quarter of those patients still have viable tumor when they head into an immunosuppressed post-transplant state...
Yeah, then the bridging therapy, frankly, just hasn't been optimized.
Exactly. So the baseline problem here is that our legacy standards anchored us to a physical dose without really fully accounting for the physics of the delivery vehicle itself.
Right, the legacy study. I mean, it was foundational for this field. It really established that 400 gray single compartment dose for glass microspheres.
But then COBRAS comes along and highlights this 24% failure rate, even at 400 gray. So to figure out why, the investigators looked at a highly specific cohort. It was a retrospective, multi-center analysis across, I think, 7 U.S. transplant centers.
Yeah, 7 centers. And they analyzed 303 patients, which yielded 364 treatment-naive HCC tumors.
And the size on those?
The median tumor size was 2.4 centimeters, so keeping them very safely within Milan criteria. And they were super strict. They specifically excluded cases of infiltrative HCC or anything with macroscopic vascular invasion.
Which makes sense for a clean data set.
Totally. And crucially, they only looked at patients treated with glass microspheres, specifically TheraSphere, who actually made it to transplant. That gives us that perfectly clean explant pathology to analyze as the primary endpoint.
So looking at this data, the whole foundational logic of our standard dose calculation starts to look, honestly, just overly simplistic. I mean, if our goal is absolute necrosis, and we know the specific activity of yttrium-90 decays hourly?
Hourly, yes.
Why did we ever think a static calculation of 400 gray would guarantee a uniform biological effect? I mean, the MIRD formula calculates total energy deposited in a tissue volume, but it completely ignores the microscopic distribution of the particles that are actually delivering that energy.
Yeah, you hit the nail on the head. Because Y90 has a 64-hour half-life. You can achieve a mathematical total of 400 grays using, say, a very small number of highly radioactive spheres, or a large number of weakly radioactive spheres.
Right, but biologically...
Biologically, those two scenarios create completely different microdosimetric environments in the tissue, even if your spreadsheet outputs the exact same total dose at the end of the day.
So the COBRAS investigators basically sought to quantify the variables that the authorized user actually controls on the day of the procedure, really looking closely at the physics inside the vial before the microcatheter even enters the patient.
Yeah, so let's break down those procedural variables because this is where it gets really practical. The first parameter they isolate is microsphere activity, or MA.
Okay.
The ROC analysis sets an optimized threshold of at least 1087 becquerels per sphere. And for anyone operating a busy interventional suite, This isn't just like a neat physics problem. It is a logistical headache.
Oh, for sure, because glass microspheres typically calibrate at what, roughly 2,500 becquerels per sphere on a Sunday.
Exactly. It's calibrated Sunday or on Tuesday. So to maintain an MA of 1087 or higher, you are strictly constrained to treating within 5 days of calibration. The isotope just does not care about your OR schedule.
And that is the daily reality in the lab. The vial can be sitting in the hot lab just decaying. So to compensate and still try to hit your 400 gray target, the software basically tells you to just deliver a larger volume of those less radioactive spheres.
Which leads us directly into the second parameter, which is microspheres per milliliter, or MPM. When you use older, decayed spheres to hit that dose target, you are forced to increase the physical particle count.
Right.
And the optimized threshold they identified for MPM is at least 8,000 per milliliter. And the study actually found this low to moderate inverse correlation between MA and MPM. It was a Spearman row of negative 0.43.
Let's actually visualize how that mathematical tangent plays out in the tumor bed, because I think it helps. Think of treating the tumor like applying a caustic acid to a surface.
Okay, I like this. The microsphere activity, the MA, is the concentration of the acid. The MPM is how many drops you are physically scattering across that surface.
Right.
So if the acid is weak, because your vial sat around and decayed, you try to compensate by scattering more drops. But nothing really beats a highly concentrated acid applied with adequate physical coverage to ensure no viable cells can hide in the gaps between the drops.
Yeah, that's a great analogy. And if we take it a step further, you know, a tumor isn't a flat surface. It's a three-dimensional sponge.
Sure.
Glass microspheres inherently have a high specific activity compared to resin platforms. And that high activity creates intense, localized hotspots. You need each sphere to project this lethal beta radiation radius.
And if they don't overlap.
Exactly. If the MPM drops below 5,000, which the paper actually flags as danger zone, the physical distribution of those spheres just becomes way too sparse. The beta radii don't overlap. You end up with these cold spots in the capillary bed where viable cells simply survive the crossfire. So we need highly radioactive spheres, and we need a dense enough suspension of them. And when you optimize those two factors, the third parameter, the single compartment dose, naturally shifts as well.
It does. The ROC analysis in COBRAS really confirms the legacy study of at least a 400 gray threshold.
Because MA, MPM, and total dose are mathematically interlinked.
Right. If you meet the thresholds for activity per sphere and particle density, you are naturally going to clear that 400 gray threshold anyway. Though it's really worth noting the authors deliberately excluded lung shunt fraction from this dose formula. But while the calculation methods weren't completely standardized across the 7 sites, the median lung shunt fraction for segmentectomy in this specific cohort was practically negligible.
What was it, around 1.3%?
Exactly, 1.3%. So when you're doing highly selective segmental or subsegmental work, dropping the lung shunt fraction from the formula is actually a very defensible simplification.
Okay, fair enough. But look, all of this vial physics completely falls apart if you deliver to the wrong vascular territory.
Oh, absolutely.
And this is where the paper pivots from the mathematics of the isotope over to the hemodynamics of the liver. The authors introduced this novel anatomical metric, the angiosome-to-tumor ratio, or ATR.
This is the real game changer. So ATR is defined as the total angiosomal perfused volume divided by the measured volume of the tumor itself.
Right.
And the threshold for success established here is an ATR of 16 or greater. In their multivariable logistic regression, achieving an ATR of at least 16 carried an odds ratio of 3.4.
Wait, 3.4?
Yes, 3.4. That was literally the highest odds ratio of any independent predictor in the entire model.
But see, if I'm standing at the console and I'm mapping vessels on a cone beam CT, this finding basically tells me to fight my core training.
Yeah, it really does.
Right, because every instinct we have as interventionalists is to superselect. We want to spare as much normal tissue as humanly possible. We use the microcatheter to get as distal and as close to the tumor as safely possible.
Right.
Now, this paper suggests we should deliberately pull the catheter back to irradiate a much larger volume of expendable normal tissue. So how does the field reconcile that with the 75 gray normal liver safety limit we're constantly taught to respect for glass microspheres?
I mean, you're identifying the central tension of the entire procedure because deliberately irradiating healthy parenchyma is traditionally how you invite riled radiation-induced liver disease.
Exactly.
However, the physiology of HCC sort of demands a broader field. HCC is notorious for recruiting these microscopic and geographically occult parasitic feeders from the surrounding adjacent liver parenchyma.
And a standard cone beam CT might not even resolve those tiny collaterals.
It definitely won't always resolve them, so if you super select right up to the visible tumor border, you are physically bypassing the origins of those microscopic parasitic vessels.
You're starving the margins of radiation.
Exactly. VTR basically applies the concept of a surgical or thermal margin to radioembolization. I think figure 1 in the paper illustrates this geometric problem perfectly.
Oh, right, the one with the volumes.
Yeah. So if you have a 2.5 centimeter tumor and you super select a catheter down to feed only a 40 milliliter angiosome, your ATR drops to 5. You severely risk missing those invisible peripheral feeders entirely.
But if you pull back...
But if you pull the catheter proximal, right, to treat a 150 milliliter angiosome containing that exact same tumor, your ATR is 18.75.
Yeah.
You shower the primary feeders and the microscopic collaterals. And because we are talking about a segmentectomy, the total absolute volume of liver being irradiated remains relatively small. You rely on the unembolized future liver remnant to sustain the patient, which makes the localized sacrifice a calculated, totally acceptable trade-off to secure the oncologic margin.
Okay, let's actually look at how stacking these 4 parameters, MA, MPM, dose, and ATR, translates into the explant pathology. Figure 3 in the paper details this stepwise increase in the positive predictive value for CPN.
And the progression beautifully validates the hypothesis. If a case only meets the microsphere activity threshold, meaning you basically just treated within the 5-day calibration window with hot spheres, the positive predictive value for complete pathologic necrosis is 74%.
Okay, then if you ensure adequate particle density by also meeting the MPM threshold, that PPV jumps to 85%.
Right, and hitting the interlinked 440 gray dose threshold keeps you at that 85% mark. The biological ceiling of the vial physics seems to sort of hover right around there.
But then, when you pull the anatomical lever, when you pull that microcatheter back to ensure an ATR of 16 or greater, the CPN rate hits 91%.
91%.
That is the headline finding right there. The combined 4-parameter area under the curve is 0.73. And honestly, on the flip side, the negative predictive value is staggering.
It is. If none of these thresholds are met, there is a 78% failure rate. The tumor almost certainly remains viable.
Bringing data like this into a multidisciplinary meeting completely changes the treatment algorithm. I mean, a 91% necrosis rate elevates radiation segmentectomy from just, a fallback or secondary option to a primary curative intent therapy.
Absolutely. It allows Y90 to compete directly with percutaneous thermal ablation now.
Which is huge, because thermal ablation has historically yielded CPN rates anywhere from, 36 to 77%. And we know that efficacy degrades really rapidly when lesions exceed 3 centimeters, or when they're adjacent to large vascular structures.
Right, because you get that heat sink effect, pulling the thermal energy away from the margin. Well, the COBRAS cohort data shows that for tumors greater than 3.3 centimeters, if they met at least 3 of the optimized parameters, they still achieved a 75% CPN rate.
Wow.
And it outperforms other bridging therapies entirely. The paper notes that TACE and SBRT consistently deliver CPN rates below 50%. This really reinforces the shift in practice patterns where radiation segmentectomy is favored for early-stage lesions, especially those located high in the hepatic dome or in subcapsular locations where percutaneous needle access is just too high risk.
Okay, so a 91% necrosis rate sounds like a silver bullet.
Mm-hmm.
But we have to be real here. This is retrospective data. If I take these numbers to my tumor board tomorrow, what are the transplant surgeons and the hepatologists actually going to push back on? Let's unpack the limitations.
Yeah, the primary pushback will definitely be the retrospective design. I mean, there was absolutely no standardization of microcatheter position, infusion technique, or even flow dynamics across these 7 institutions.
And the findings are strictly limited to glass microspheres.
Yeah.
You cannot extrapolate an MA of 1087 or a 400 gray dose threshold to resin platforms. I mean, the specific activity of resin is lower, so it requires a different density and dosimetric approach altogether.
Yeah, you just can't compare them. There is also a significant selection bias woven into this data. Several of the major participating centers were already early adopters of these optimized thresholds prior to the formal study period.
So that artificially narrows the data distribution.
Exactly. In a broader, community-based, less optimized population, the signal might look completely different.
Right. Furthermore, they only analyze patients who actually made it to the operating room for their transplant. And we know from national registry data that there is roughly a 20% dropout rate for patients on the waitlist receiving bridging therapies.
Right. They progress, they decompensate, or they die.
Yeah. So by excluding those patients, we're basically looking at a selected group of survivors, which obviously skews the perception of overall procedural success.
Which brings us to the most critical limitation we really have to acknowledge. Complete pathologic necrosis, while highly validated in transplant oncology, is still just a surrogate endpoint.
Good point.
COBRAS definitively proves we can reliably kill the tumor and clear the microscopic margins on the pathology bench. But it leaves open the ultimate question. We don't yet know if prospectively hitting these 4 specific parameters translates into a statistically significant improvement in overall post-transplant survival. The optimized ATR of 16 hasn't been mapped out to long-term Kaplan-Meier survival curves yet.
Right. We're basically assuming that a better explant translates to a better decade for the patient, but the long-term data just isn't in this specific paper. Still, the shift in daily practice mindset is super clear.
Oh, absolutely.
We are no longer just looking at a spreadsheet asking if we hit 400 grams. We have to look at the decay calendar to ensure a high microsphere activity. We have to monitor the particle density. And critically, we have to evaluate that angiosome-to-tumor ratio on the cone beam CT workstation before we ever even open the vial.
Because the dosimetry of yttrium-90 is a physical, spatial, and temporal problem, it requires manipulating both the physics of the isotope and the hemodynamics of the target organ simultaneously.
If this paper is correct, the one specific change you might make in your practice tomorrow is calculating the angiosome-to-tumor ratio during your mapping angiogram, deliberately pulling the microcatheter back to achieve a ratio of at least 16 to secure your ablative margin. It really makes you wonder, though, if securing an ATR of 16 is this critical for transplant patients with preserved liver function, how aggressively should we be pulling the catheter back in our palliative, non-transplant HCC population where hepatic reserve is already hanging by a thread?
That is the next frontier of the dosimetry debate, without a doubt.
Now, here is an expert commentary from Dr. Sid Padia from UCLA Interventional Radiology.
So COBRAS was a multi-center retrospective study looking at pathologic CPN rates after Y90 radiation segmentectomy. And it really kind of extends on the data initially by the legacy study showing a benchmark of 400 gray to achieve CPN, which they showed in 100% of the patients in the legacy trial. So I think the main addition to our clinical practice is the addition of potentially more variables to consider other than just dose, which in this case is 400 gray and higher, or let's say in this case 440 gray. So what else can we add in our regular practice based on this data? I think the most important thing is to really consider the number of particles per cc of perfused tissue. In other words, you have a big area that you're treating. Infusing a very small number of particles is probably not going to get you enough homogeneous radiation throughout the tumor. So what Berman and colleagues have done is calculate that to achieve high rates of CPN. And if you can achieve, a greater than 9,000 particles per cc of perfused tissue, then you can potentially achieve higher rates of CPN. I think one of the challenges of doing all these variable calculations for radiation segmentectomy is that our results are already so good in that we are getting objective response rates above 95%, complete response rates above 95%, that it's hard to figure out where our failure points are because the failures happen so infrequently. And so it's extraordinarily challenging to do these multivariate analyses when you analyze several hundred patients and everyone seems to be a success and you don't really have a good way of comparing them to the failures. That's one of the challenges even in the COBRAS study. They're not necessarily looking at the failures. The failures are most likely those patients who didn't get liver transplantation. In other words, that patient that had a 4-centimeter tumor, had a radiation segmentectomy, they progressed, so they got something else, or maybe they developed multifocal disease, and so they were never a transplant candidate. So what about that patient? Well, that one is not necessarily included in this analysis. I think the second challenge is this introduction of another concept called the ATR, the angiosome-to-tumor ratio. As the commentators mentioned, that the concept to pull back your microcatheter and treat a larger area of liver is, and I completely agree, really counterintuitive to the way we practice liver-directed therapy. So the one thing to keep in mind when doing that, that's not always possible with patients. Sometimes you might be in segment 8, and if you pull back to increase your ATR to 16, you may end up treating half the right hepatic lobe. So is that really something you would want to do for a 2-centimeter tumor? Similarly, in regions with long transplant wait times, you are often going to have patients who develop a second tumor down the road, a third tumor, even if they are on the transplant wait list. So it's not simply a matter of preserving enough hepatic parenchyma during that one treatment. It's a matter of preserving the hepatic parenchyma to allow for multiple treatments down the road, even if liver transplant is 2 years away or 3 years away or even 10 years away or never in their horizon. So I think we need to be mindful of that in terms of liver preservation. Frankly, I would much rather have a 90 to 95% response in a single tumor and spare as much hepatic parenchyma as possible versus, let's say, treating half the right hepatic lobe by pulling back too proximally. So that's one, I think, the areas of deficiency of this research design.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.